Welcome to QD Clinic. I'm Jack Cush with Room Now. QD Clinic this month is brought to you by Sanofi, the sponsors of our campaign called Make Room for PMR. Today's case is a 52-year-old who had a great response to steroids. The question is this PMR? So she presents to you for a second opinion. 4 months ago, she had the onset of knee pain, and it was associated with some swelling. It was just on one side, the right side. And then 2 weeks later, it became bilateral shoulder and bilateral hip and bilateral knee pain. Mostly not swollen, but she really wasn't sure. At one point, she was unable to get out of the bed because of the knee and shoulder pain. She had 2 hours of morning stiffness. She had pain in the joints mentioned. Labs were drawn by our primary care. The SED rate was 58. The CRP was markedly elevated at 6.35 milligrams per deciliter. She complained of weakness, fatigue, myalgias, and anorexia. She hadn't lost any weight. She denied any fever. She had no rashes. She was seen by rheumatology, who put her on prednisone 15 milligrams a day, and she did dramatically better and was able to resume her activities. She went back and saw that rheumatologist, who started to wean her down, and she promptly got worse. And this was probably after being on steroids for maybe a month. She comes to you for a second opinion. She still has pain in her shoulders, knees, and hips. 4 hours of morning stiffness despite being on prednisone 12.5 milligrams a day. She says her pain today is 4 out of 10. She sleeps poorly and takes medicine for it. Her current meds include prednisone 12.5 milligrams a day, PRN hydrocodone. She takes Keppra for cluster headaches, and for her bad sleep, she takes QHS, amitriptyline, and elscolpizone or Lunesta. She's also on a statin. When you see the patient, there are no tender joints, no swollen joints. She has full range of motion in the hips and shoulders. The SED rate's 5. The CRP is 0.5 milligrams per deciliter. Question is, what's your diagnosis, and what are you going to tell her? I mean, she's coming to you. Either you're going to confirm the diagnosis of PMR or tell her she got something totally different. I think what's curious about this case are the facts that the CRP is very high. She had prolonged morning stiffness. She had girdle pain. She was unable to get out of bed. It's a common story. And she had anorexia. But sort of the sequence of the events here is a little odd, especially with the knee pain and bilateral knee pain, the association with bad sleep, the inability to get off steroids. I wouldn't expect that early on in the story. But I think the question at hand here is this PMR, and was it confirmed by the Exquisite response to 15 milligrams of prednisone? The answer is a blatantly loud, unequivocal no. Steroid responses are non-specific. I don't care if your problem's a hangnail or a migraine headache or stage 4 leukemia. Steroids make a lot of people feel better, and for no particularly good reason. And so hinging a diagnosis on that may be problematic. I don't believe that the former rheumatologist was really saying that this was a final diagnosis. I think he was impressed that he had to do something quick because this patient was non-functional with a very high CRP. And I think I would have done the same thing. However, if you really doubt the diagnosis of PMR, I mean, this person is 52 years of age. I can count on one hand the number of patients I've diagnosed with PMR who are age 50 to 60. So I don't like making that diagnosis at that age. So if you doubt the diagnosis, an empiric trial of steroids in someone with acute onset inflammatory arthritis seems prudent. And what do? I tend to give an intramuscular dose of something. I like depomedrol, 80 milligrams, followed by 10 days of prednisone, either 10 milligrams a day or 20 milligrams a day, but then abruptly stopping and having the patient call me 4 to 7 days later to let me know what's going on, and then I'll make up my mind. But I'm not going to rely on steroids. I'm not going to start steroids with the future guarantee that getting them off steroids is going to be really difficult, as it is in this case. So I would say that there was an onset of a probable acute inflammatory arthropathy. Etiology, who knows? Most of those do go into remission on their own, and a little bit of steroids can't hurt. At this point in the game, she still has joint complaints. Maybe you want to look for other causes of an acute evolving into now a chronic arthropathy. I don't know if she has inflammation because she's on steroids and her acute phase reactants are negative. She has no swollen joints, but I'll nonetheless look at her scalp and at her skin and ask her about her GI habits. And I'll probably refer her, if any of those are abnormal, I'll refer her to derm or GI, but that wasn't the case here. I didn't find anything on exam. I might consider, because of the chronicity of the complaints, imaging. And if the shoulders are still a problem, ultrasound to help diagnose PMR might be good. Otherwise, given the complaints she has, I might do x-rays, just plain radiography of the shoulders, hips, and knees, because they have been chronic. But she does have normal range of motion, so I expect that to be a low yield endeavor. It's clear that above all, she does have poor sleep, and poor sleep can account for all of this, manifesting as overt fibromyalgia or even poor sleep causing myofascial pain that's widespread. She does not have tender points. She does not meet criteria for fibromyalgia. But I'm nonetheless giving her instructions on sleep hygiene, sending her to a sleep eval with a specialist, and changing her sleep meds to less amitriptyline, more trazodone, using the Lunesta PRN, and giving her a plan to wean steroids in a very slow 1 milligram per every other week fashion, or every week fashion, while covering her with daily analgesics like 1900 to 2600 milligrams a day of extended release acetaminophen. Time will prove that she doesn't have PMR, and I'm sort of certain of that. I won't get hung up if her CRP is elevated persistently. I won't, because I don't treat lab tests. I'm treating inflammatory arthritis, and I don't see inflammatory arthritis. So elevated CRPs, I'll just watch them and worry about them, but I'm certainly not going to prolong prednisone because of a test or an acute phase reactant in someone who doesn't have established diagnosis of PMR. That's it for this QD Clinic. Tune in for more during this campaign month on Make Room for PMR.